Welcome, everybody. Thank you for joining us today. My name is Melissa Stevens, and I'm the 2024-2025 chair for the VIU Faculty Association Women's and Gender Equity Committee. And Sarah, my colleague, is also on that committee. And we've been working really hard for the last couple weeks to support a campaign for the United Nations 16 Days of Activism Against Gender-Based Violence, and that started on November 25th. And we had a clothesline project that we installed in the cafeteria of the Hill with messages of advocacy and hope around gender-based violence. And we have a series of other events, and this is one of them. Of course, this is also supported and sponsored by the Harm Reduction Alliance. So Sarah Lovegrove is a registered nurse, professor in the Bachelor of Science in Nursing here at VIU. She is the faculty co-lead for the VIU Harm Reduction Alliance and the vice president of Harm Reduction Nurses Association. She has previously practiced as an emergency department nurse in both Cowichan and Nanaimo and has been involved in advocacy work alongside and in support of people who use drugs in the context of a toxic drug crisis since 2018. And before I turn it over to Sarah, of course, I also want to recognize that we are on the unceded territory of the Nanaimo people, and as a white settler, I'm very grateful that we're able to get gathered today and address this topic. So thank you, Sarah.
Thank you, Melissa. Can everyone hear me if I just talk like this volume? Good. Just tell me if you need me to be louder. So I too just want to acknowledge that I am very grateful to be gathered with you today on the traditional, stolen, and unceded territory of the Nanaimo First Nation as an uninvited white settler and someone who has been working within the context of this toxic drug crisis for nearly 8 years now. I have a tremendous amount of gratitude for the beautiful territory and for the Nanaimo people who have been the stewards and caretakers of this land since time immemorial. Throughout our time together this afternoon, I will outline how the toxic drug crisis inherently began at the time of European contact on Turtle Island, and much like the devastating genocides currently happening in Gaza, Yemen, Sudan, and many other countries across the world, this deadly crisis is rooted in colonialism and the intergenerational impacts of colonial violence. I also want to take a moment to acknowledge and express my deepest gratitude to the many people with lived and living experience with substances who have shared their experience and wisdom with me. Everything I know and share with you today is because they have taught me. The compassion and empathy I have for people who impacted from this crisis comes from knowing, loving, and learning from people who use drugs. Everything I do is to honor them and the people I've lost. Harm reduction has always been and will continue to be a grassroots, community-centered movement that pushes back against the politics of a colonial capitalist patriarchy, defying the Western medical industrial complex that decenters the expertise of community, culture, and the people who need support the most. People who use drugs take care of one another when no one else will. They are the expert at their own experience, and nothing should ever be decided without them at the table. I also just want to offer this little content warning for everyone. I'm sure all of you came here knowing this, but we're going to be talking about overdose, death, substance use, addiction, mental health, trauma, and systemic oppression. So if you start to feel any sense of like activation or overwhelm, please do what you need to do to take care of yourself. Leave the room. I will not be offended. But it's also important to remember that being triggered is being different than feeling challenged in your deeply rooted ideologies and belief systems about drugs. Therefore, if these feelings arise in your body, this is an invitation to consider this an opportunity to check in with yourself, as an opportunity to examine your own implicit and explicit biases that may offer a chance to identify areas for personal growth and professional evolution. It's my intention today to have each of you leave this room a little bit more of an ally than you walked in. So I'll just introduce a little bit about me. Above all else, I like to consider myself a human learning to be human, but like Melissa said, I'm a nurse, I'm a professor, and I'm an activist, but I also consider myself a drug user. In late 2018, I left my job in the emergency department with severe post-traumatic stress disorder, and through my time of feeling and healing through that, I utilized the drugs, cannabis, and psychedelics in order to heal. And I consider myself someone who uses cannabis on a pretty regular basis, just to live my daily life. But I identify as this with an awareness of my privilege in that the drugs that I consume are not at risk of contamination because they're both natural and or legally regulated. I worked alongside and in support of drug user groups. I was the chair of the Nanaimo Community Action Team, and I'm currently the vice president of the Harm Reduction Nurses Association. As an intersectional feminist, I operate from a decolonial, anti-racist, anti-oppressive framework. And my nursing and teaching is deeply rooted in equity-oriented practices, which is an integration of harm reduction, cultural humility, and trauma-informed practice all put into one. This is also my dog, Luna. She's not here today, but I wish she was. She's my therapy dog, and she tends to come with me to most of my activism events and is present at all of them. Everything that I do is centered in human rights. For me, every single person is worthy and deserving of love, safety, and the right to adequate social determinants of health. And the way I see it, drugs are morally neutral. They're neither good nor bad, but rather I recognize that substance use is a valid adaptive coping response to trauma and existing in traumatic systems of power and oppression. I recognize as well that there are multiple trajectories into, within, and out of addiction, and multiple experiences of non-problematic or recreational use. It's within all of my work that I recognize as well that every drug toxicity death is a policy failure rooted in systems that are designed to cause harm. And finally, I firmly believe that we're the ones who have been brought here to change the world. So we've all been brought here at this time of crisis, and it's up to us to make the world a better place. So I just wanted to acknowledge at the very beginning that I'm going to be talking a lot about numbers today, a lot of statistics, and each of those numbers and statistics makes up a human life. So we have, since April 2016, we've lost 15,602 British Columbians to this crisis. Across our country, 22 people a day die in Canada of toxic drugs, which is the equivalent of a public school size classroom every single day. We are now in the 8th year of a public health emergency declared by BC's public health officer in April 2016. And we've seen very little movement on doing the things that we need to do to make this crisis go away. The cumulative number of unregulated drug deaths in 2024 alone in BC is 1,749, and this accounts for 6 to 7 deaths per day in BC. 70% of those dying were aged 30 to 59. When we talk about where people are dying, a lot of people will make assumptions about the visible homelessness and substance use that we see on the street, but 81% of unregulated drug deaths actually occur indoors. So 48% in private residences, 32% in other residences, including supportive housing, SROs, shelters, hotels, and other indoor spaces, and only 19% of total deaths occur outdoors in vehicles, sidewalks, streets, and parks. I offer this to you simply as a broader context, not as a comparison of severity or importance of these deaths, but I recognize that this past Monday was World AIDS Day, and between the years of 1993 and 2002, there were 4,944 deaths among people with HIV in BC. And as you can see here, we've far surpassed those numbers with the toxic drug crisis in a matter of 8 years. We've also surpassed the BC number of deaths about COVID as well. With COVID, BC saw 7,394 deaths, and we're far surpassing that right now with the 15,602 deaths as a result of a toxic drug crisis. And I put this up just to really contextualize this crisis in terms of the number of people who have died. But also, I just want to recognize that we curbed the morbidity and mortality rates of HIV and AIDS and COVID with harm reduction. We've included ready to access to clean needles, condoms, masks, prophylaxis medications, and vaccines. And all of those interventions worked to curb the morbidity and mortality rate of HIV and AIDS as well as COVID. And we have the opportunity to do that with toxic drugs as well. Here in Nanaimo, approximately 535 people have died from an unregulated supply of drugs since the province declared the overdose crisis, which is an average of approximately 8 to 9 deaths per month in our little town alone. People in our community aged 25 to 44 years are injured and dying at the highest rate, with the majority of deaths occurring among males. Locally, the number of people dying outdoors continues to rise, and And this is disproportionately higher than the provincial rate, with the 2023 point-in-time count reflecting far greater than 515 people living without shelter in Nanaimo. This is actually estimated by people on the front line to be well over 1,000. The data reveals that as the number of people experiencing homelessness increases in our community, so too does the rate of people dying outdoors from an unregulated supply of drugs. Additionally, exactly 1/3 of those surveyed identified them in the point-in-time count, identified themselves as First Nations, Métis, or having Indigenous ancestry, which is the same ratio as the 2020 data. Yet Indigenous, Métis, Inuit, and First Nations individuals only make up about 6% of the Nanaimo population. In 2023, Dr. Lisa Lapointe, former chief coroner for the province of BC, made the grim announcement that unregulated drug toxicity is the leading cause of death in British Columbia for persons aged 10 to 59, accounting for more deaths than homicides, suicides, accidents, and natural diseases combined. And I just want everyone to just take a deep breath and let that sink in. Age 10 to 59, it's the leading cause of death in our province. And all of these issues, homicides, suicides, accidents, natural disease combined, the toxic drug crisis outweighs the number of deaths from all of those. And Dr. Lisa Lapointe actually quit her job last year because the government was not taking this seriously enough and wouldn't follow her guidelines. So we've evolved quite a bit in this overdose and toxic drug crisis. We've had, if you've been a part of it for a long time or been watching the news, you know that we've changed names several times. So back in the late 90s, early 2000s, it was called an opioid crisis, then sort of evolved into an overdose crisis. And more recently, around the COVID time, we started calling it drug poisoning crisis, and now a toxic drug crisis. And this evolution is because the cause of death is no longer because someone took too much of an opioid, but rather consumed a substance with an unpredictable content and potency. Increasingly, the toxic supply is becoming more potent and more unpredictable with numerous adulterants. So once upon a time, there was something you could buy called heroin. That's not something that really exists anymore that you can buy off of the street. If you're going to buy heroin now, it's called down, and it's an unpredictable combination of fentanyl, carfentanil, benzos, tranquilizer called xylazine, and other substances like drywall dust and rat poisons. Ultimately, this leads to an unknown and inconsistent supply and potency, which really worsened at the time of COVID due to supply chain impacts, as well as increased deaths due to social isolation and the shutdown of services. With advanced testing that we have now, there's a number of different opportunities to release drug alerts, such as this one here, informing people when there's a particularly bad batch of drugs out there. This pill, for example, was sold as oxycodone, what looks like an oxycodone pill, but is actually only tested positive for fentanyl and xylazine and negative for oxycodone. So that gives a bit of an example as to like the unpredictability of what you're buying out there. So how I'm going to explain this is how my brain understands the toxic drug crisis. And so we're starting here at the center with, we always centralize substance use and unregulated drug deaths. I don't separate the two because anyone who consumes substances right now is at risk of toxic drug deaths. And when we think about those drug deaths, we're going to zoom way out and we're going to think about how all of this started with colonialism. So everything we do, everything we consume, all the way that we work in the world is all influenced by colonization and the colonialist way of being in the world. So throughout colonization, Indigenous community-based practices of collectivism were replaced by Eurocentric values of individualism and with the paternalistic prioritization of Western knowledge and medicine. With this also came the inherent erasure of Indigenous ways of being, knowing, and healing. Through acts of force and control, Indigenous peoples and cultures became separated from their traditional and spiritual ways of being. And when combined with the intergenerational traumas of colonization and the introduction of substances like alcohol into trade agreements, Indigenous peoples became disproportionately susceptible to westernized ways of coping with trauma, including the use of substances. Within the system of colonization, 3 European structures of power were able to flourish and prevail, including white supremacy, patriarchy, and capitalism. From the 1500s on, fur traders, missionaries, and European colonizers from Britain and France introduced alcohol to Indigenous communities when they settled in the lands we now call Canada. Alcohol was exchanged at trading posts for valuable items like furs, and its introduction and devastating impacts on Indigenous communities prevailed from that point on. Colonizers brought alcohol with them for personal use, but quickly realized the power that alcohol had and how it could be used to hurt Indigenous communities. Trading alcohol took off during the fur trade, where rum and brandy would be exchanged for animal skins rather than profit, which caused poverty amongst communities. Colonial powers took advantage of their struggles and used addiction to spread misinformation and racist stereotypes about Indigenous peoples, contributing to intergenerational trauma amongst Indigenous communities. At the time, alcohol was a drug of choice for Europeans, but there was growing opposition to its consumption by some moral reformers who viewed it as a corruptive force. At the time of the Indian Act in 1876, white moral reformers were also focused on converting Indigenous communities to Christianity, and so this goal, along with the prohibition of alcohol, became their focus. Vancouver was the birthplace of drug prohibition in Canada, driven largely by anti-Chinese racism and a perceived threat to white middle-class purity. Chinese men arrived in Canada to work on the Canadian Pacific Railway in the 1880s, and when the railway was finished, many settled in Vancouver. Swayed by his meetings with opium reformers, former Prime Minister William Lyon Mackenzie King became one of the early evangelists for prohibition in the federal government. Absent any evidence or debate in Parliament Hill, the Opium Act of 1908 was passed and enacted, thereby putting Canada on a dangerous path to prohibition that would cause more harm than good. The Opium Act was legislation targeting Chinese Canadian men and was grounded in anti-Chinese racism. So cultures and narratives about drugs inherently come to Canada from the US. So there's a war on drugs declared in 1971 by President Richard Nixon, which was racially motivated as a means to control minority populations within the US, intentional misinformation, and propaganda. And I'll just read you this quote by John Ehrlichman, who is the assistant to the President for Domestic Affairs in 1971, quoted to Dan Baum for Harper's Bazaar magazine in 1994. He said, "The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did." So drug laws and policies, especially in the US, disproportionately impact Black and Brown communities. For example, there is longer minimum sentencing in the US in place for substances like crack cocaine compared to powdered cocaine, which is a differentiation between basically chemical makeup, but primarily who consumes those drugs. As powdered cocaine is more of a privileged drug, and crack cocaine, as being a cheaper form of it, is often sold on the streets. Additionally, significantly more Black people continue to serve prison time in the US for cannabis possession. With these policies in place, prisons are occupied primarily by Black, Brown, Indigenous people with objectively minor drug convictions. The prison industrial complex has also evolved into a form of modern-day slavery in that corporations utilize low to no-pay prison labor for manufacturing of low-cost goods, with laborers disproportionately comprised of Black and Brown prisoners. When governments position criminalization as a solution and law enforcement as a primary intervention for this toxic drug crisis, we simultaneously see the inflation of police budgets that will seek to maximize criminal penalties for drug users. Our local police budget, for example, comes from municipal taxpayer funds. So the more inflated the police budget is paying for armored vests and taser guns, the less funding we have in our community for social services, housing, food security, and infrastructure. With this, it's also essential to consider the direct implication of enforcement on the toxicity of the drug supply. To contextualize this, we have what's called the iron law of prohibition, which is the demonstrated pattern that when law enforcement power is increased and the incidence of drug busts rises, so too does the potency of illicit substances. We saw this throughout the prohibition of alcohol, when people started to make homemade moonshine that led to blindness, disability, and death. We saw it when cannabis was illegal and the demand for higher potency THC products came about. And we see it now with the illicit supply of opioids. To avoid law enforcement detection at border crossings and for discreet trafficking, illicit market sellers moved away from moving pounds and pounds of raw opium and raw heroin to selling higher potency chemical analogs like fentanyl and carfentanil that can be made in someone's basement lab and transported with fairly low risk of detection. For a visual effect, this kind of comparison between lethal doses of fentanyl, carfentanil relative to that of heroin. So you can see that the dosages and actual amount that you would need to cause a lethal reaction or have the same effect is much smaller when it comes to carfentanil and fentanyl. So as a result of these inflated police budgets and disproportionate funding models, we have established a world in which everyone cannot afford to exist. Living below the poverty line has become a common experience, and most people are 1 or 2 paychecks away from being unable to pay for their rent, groceries, and bills, including myself. What most people do not realize is that we have far more in common with the people who are living rough or unhoused than we do the capitalist millionaires and billionaires objectively hoarding and controlling all the resources. With mass gentrification throughout communities to cuts to social housing initiatives over the last 2 decades, we're also sitting collectively within the depths of a housing affordability crisis. There is a significant narrative out there that drug use leads to homelessness, and that if people would just pick themselves up by their bootstraps and get off drugs, they would be able to afford a home. But people who continue to work full-time and participate in quote-unquote productive member of society are forced to downsize, live in their cars, or spend nights living on the streets. The reality that I hear most often from folks is that people who are forced into homelessness actually begin their journey with substances there as a means of coping with that stress. To numb themselves from the fear of living on the street, to stay up all night, to keep their belongings safe, or to escape the terrifying reality that they're existing in. This housing crisis also sits at the crux of a concurrent healthcare crisis, wherein our infrastructure is aging and insufficient to meet population needs, scan to NRGH. We do not have enough physicians to meet the needs of people in our communities, and our nurses are burning out and leaving their profession in droves. The inherent implications of capitalism are most notable when we recognize the impact of supply and demand. While a thorough discussion on the pharmacodynamics of opioid use is beyond my capacity within the context of this discussion, 2 important realities are important to convey here. 1, that physiological dependence is an expected and anticipated outcome with prolonged opioid use of any kind, and tolerance to opioids naturally happen over time with prolonged use, eventually requiring increased dosages or stronger potency opioids to meet their same needs. In the 1990s, pharmaceutical companies like Purdue Pharma, run by the Sackler family, recognized this as an opportunity to make money when they falsely marketed the drug OxyContin to doctors as being lower risk for addiction, which quickly evolved into a crisis of overprescription, wherein many people developed physiological dependence. As this issue became increasingly detected within the medical community, there was then a swift movement towards a mass deprescribing of opioids without careful consideration of where people would turn next to meet their needs. The illicit market was able to capitalize on this, offering illicit options for OxyContin and stronger opioids such as heroin. To keep up with the demand for stronger and stronger opioids, the illicit supply met that need with the additions of stronger chemical analogs into the mix, including fentanyl and carfentanil and other adulterants that allowed for longer drug duration of effect. We also have a market for recovery and treatment that is almost entirely privatized and unregulated, allowing for private companies to offer non-evidence-based treatments and recovery options to the tune of $25,000 to $40,000 per treatment session, forcing families to remortgage their homes and empty their savings just to get their loved ones into substance use treatment spaces that are inevitably going to save their lives. With relapsing of drug use also being an anticipated experience within the recovery journey, this private industry is making bank repeatedly on people who are suffering and their families who would do anything to keep them alive. Although this crisis is one that touches and impacts all people from every walk of life and every degree of marginalization of privilege, it does impact many groups of people in disproportionate ways. When I think about the patriarchy and the way it plays into this toxic drug crisis, we see it most significantly in the ways in which people experience the disproportionate impacts. When we talk about youth, it's grim data. Unregulated drug toxicity has been identified as the leading cause of unnatural death among youth in BC. From 2019 to 2023, there were 126 unregulated drug toxicity deaths in BC of persons younger than age 19 years of age, which equates to about 25 deaths a year of youth. About 2/3 of people who died were in receipt of current or previous services offered through the Ministry of Children and Family Development. And 67% of people who died had a mental health diagnosis or anecdotal evidence of a mental health disorder. To dispel any assumptions, myths, or misinformation about safe supply being the culprit of these deaths, it's important to note that fentanyl or its analogs were detected in 83% of those deaths, either alone or in combination with other substances. Dilaudid, or what is safe supply right now, was detected in only 16 deaths, and in 11 of those deaths was found in concentrations below or within the therapeutic range and unlikely to have contributed significantly to the death. In all 16 deaths, at least one other substance was found that contributed to that death. There is a distinct lack of race-based data in the toxic drug statistics from the BC Coroner Service. We have no information about race and how race is impacted by in this crisis, but we do have data collected from First Nations Health Authority. What we know from the US is that although white and Black people use at similar rates, fatal overdoses have escalated in Black people at a much higher rate than in other groups over the last decade. And multiple recent studies have documented especially high rates of overdose death among older Black men in the United States. But according to the First Nations Health Authority here in BC, First Nations people in BC died at 6.7 times the rate of other BC residents in 2024. The toxic drug emergency has also had the greatest impact on decreased life expectancy for First Nations people, followed by COVID-19. As a result of these two public health emergencies, life expectancy has decreased for First Nations by an average of 7.1 years, while comparatively life expectancy decreased only 1.1 years for other non-First Nation residents of BC. In 2024, women represented nearly 40% of all First Nations toxic drug poisoning events, and First Nations females are dying at 11 times the rate of other BC residents. First Nations women sit at the intersection of multiple forms of marginalization, and with the same colonial genocidal energy that women, girls, and two-spirit kin are disproportionately missing, murdered, and erased, First Nations women in BC are significantly impacted and eradicated as a result of the racialized policies that force them further into the margins of our world. Unfortunately, we also have no data based on 2S LGBTQIA+ identities from the BC Coroner Service. When it comes to coroner data, the data is taken based on what appendages and pieces the body has lying in front of them. So it's either male or female. But existing research shows that 2S LGBTQIA+ adults are more than twice as likely to use illicit drugs and almost twice as likely to suffer from a substance use disorder. This is a result of increased experiences in trauma, harassment, discrimination, stigma, lack of support from family, community, including family, community, and services, and internalized homophobia. When I consider the impacts and influence of the patriarchy on this crisis, I think about how people experience their mental health, how they experience trauma, and how they are supported in communities. As a feminist who's been learning and practicing from an intersectional framework for over 2 decades, it's not often in my practice to prioritize the implications of policies on men. But when we look at the data and impacts of this crisis, it is men who are suffering and dying at the highest rate. The latest information from the BC Coroner Service indicates that 74% of toxic drug deaths in BC are occurring among males. And when we contextualize this alongside other data presented, the picture of those who are impacted includes middle-aged men, often working within the trades, dying alone in their homes as a result of stigma. As a result of a patriarchal system that tells men to be tough, not show emotions, and not reach out for help, men are suffering and dying alone. So as a result of these various systems of power and manifestations of institutional oppression, we have an entire generation of humans on this planet experiencing crises related to mental health and trauma, including generational trauma for an entire generation of children grieving the loss of their parents, family, and friends. When learning from Indigenous elders and knowledge keepers, they often refer to family members and loved ones impacted by substances as experiencing what they call a spiritual crisis, as though their spirit has been lost or disconnected from their being. And it is only through the reconnection to culture, community, and family that their spirit can be returned. But amidst this crisis of toxic drugs, they are lost too soon for that healing to happen. So, shift a little bit, and we're going to talk a little bit about what the response from our government has been for the past 8+ years of a toxic drug crisis. And I fully admit that I am not objective in this, but I also have had my eye on the politics of what has been happening over the last 8 years, and I've done a lot of research about it. So if I can sum it up into 2 topics, it would be moral panic and reactive politics. Essentially, politicians over the last 8 years have been responding primarily to the loudest and most privileged voices, and usually that's white people. We also see what we begrudgingly like to call TikTok politics, and we saw this quite obtusely in Nanaimo over the last election when we saw the suspension and removal of the Care and Connection kiosks offering harm reduction and wound care supplies from our emergency department. It was put in a suspension for review based on a social media TikTok video from Nanaimo-Lanceville Conservative candidate Gwen O'Mahony. And I personally know at least 6 people who have been impacted by that, including one death of an elderly gentleman who didn't have access to fentanyl testing strips because of that closed down vending machine. We also see politicians intentionally ignoring scientific evidence and guidance of advocates and health professionals, including BC's provincial health officer, Dr. Bonnie Henry, when she recommended in February 2024 that the province expand its safer supply program to prevent overdoses. These suggestions were rejected by former mental health and addictions minister Jennifer Whiteside, citing that the province does not agree with the recommendation and will not go in the direction of non-medical models of distributing medications. Bill 34 was an act passed in November of 2023 by the BC NDP that was set to come into law on January 1st this past year, which proposed recriminalizing drug use in a broad range of most public spaces and threatens the safety of the most vulnerable communities, and would give power to the police to redirect, fine, arrest, and seize property when the police officer has reasonable grounds to do so. If that passed, this bill would promote hidden or isolated drug use, drive the displacement of people who use drugs, especially those who are unhoused, into further isolation, rely on services that do not exist in our communities, and disproportionately target and harm Indigenous peoples. In response, the Harm Reduction Nurses Association, with the support of lawyers from Pivot Legal and the Canadian Drug Policy Coalition, submitted a legal challenge to prevent the law from coming into force. We asked the Supreme Court of BC to declare Bill 34 unconstitutional as it violates core rights and freedoms under the Charter. On December 29, 2023, so right before it came into law, the BC Supreme Court granted us an emergency injunction, citing the bill would cause irreparable harm. And we are still waiting to appear before the BC Supreme Court in 2025 for the full case. At the demand of drug users and advocates, a 3-year pilot project was set into motion in January 2023 that decriminalized the personal possession of small amount, or 2.5 grams, of select substances. But when Bill 34 did not work to make it illegal to consume these drugs in public spaces, the BC NDP made the bold move to essentially reverse decriminalization in public spaces in April of 2024. There is also an extremely dangerous war on harm reduction happening across Turtle Island right now, wherein many conservatives or right-wing politicians are skewing their solutions to this crisis through the prioritization and redirection of funding to recovery and treatment instead of harm reduction. While we desperately need more publicly funded recovery beds, it is important to know that harm reduction includes all of this. Solutions are not an either or, but rather a both and then some. Overdose prevention sites, for example, are a hotly contested subject. Pierre Polyev refers to them as drug dens, but they actually serve so many positive benefits for communities, healthcare workers, and people who use drugs. Not only do these sites keep people alive, overdose prevention sites also serve as a crucial door in for multiply marginalized people, including sex workers and unhoused people who use drugs. OPSs have become politicized in BC and Ontario. Most recently, the BC government ordered for plans to implement safe, life-saving OPSs at the Island Health Hospital sites to be halted, despite years of plans and advocacy for this dire need. This past Monday, in Ontario, Doug Ford's government passed Bill 223 that will order the closure of almost all safe consumption sites in Ontario, as well as prevent organizations from receiving federal funding for harm reduction services like safe supply programs or applying for decriminalization. Currently in Ontario, there is already someone dying every 2.5 hours from toxic drug crisis. And this law actually passed through royal assent just a couple of hours ago. So it is now a bill that's been turned into a law. Saskatchewan enacted laws to restrict needle exchange programs and cut funding to harm reduction in January 2024. And they are now seeing the highest HIV transmission rates in Canada and new cases of HIV rising across the country. In Alberta, HIV rates have been steadily increasing as a result of major funding cuts to harm reduction services in the past few years in favor of a recovery model. Current BC safe supply models, despite being asked for by people who use drugs and advocates, are not sufficient in the way that they are to meet the needs of the people who currently access the illicit supply. The BC coroner estimates that 225,000 people are at risk to unregulated drugs in a year in BC. And the last update from BC on safe supply access from July 2024 states that there were 4,029 people being dispensed a safe supply, which means that approximately 1.8% of people in BC who are at risk have access to safe supply programs that meet it. So when you hear safe supply doesn't work, it doesn't work because we're getting crumbs when we ask for a full meal. Additionally, involuntary treatment, or involuntary care, as they call it, has become a politicized solution during the last provincial election to deal with people with brain injury, mental health, and severe addictions. This plan involves the proposed expansion of the BC Mental Health Act, but currently we do not actually have enough voluntary spaces for support and treatment. We are limited in staffing and infrastructure, so the aim of the government is now to encompass the use of correction centers and prisons as a space to solve this form of care. We do know that success rates of involuntary treatment are less than 4%, and people are 2 times more likely to experience fatal overdose upon release because they come out of these treatment programs being completely opioid naive. Considering the disproportionate impacts of substance use, homelessness, and criminalization, establishing laws around involuntary care for substance use is not a culturally safe approach and puts women, gender expansive, and Indigenous peoples at much higher risk of being traumatized and risks re-traumatizations, as these methods are reminiscent of intergenerational experiences, including residential schools and the 60s scoop. So what do we have for evidence-based solutions? First and foremost, we need to legalize and regulate the drug supply. And I know this comes as a massive shock to people, but according to the BC Coroner Service Death Review Panel that convened on November 1st, 2023, the primary driver of this drug crisis is in the inherently toxic and unpredictable nature of the unregulated drug supply. So just like our government responses to the sale of illicit alcohol and cannabis, the only logical and appropriate option to curb the toxicity and of the illicit supply of drugs is to legalize and regulate it. Additionally, we need to increase the number and accessibility of government-funded voluntary treatment and mental health care options for people ready to make change. These changes should be regulated, ensuring they are trauma-informed, culturally safe, and offering recovery options for all people, wherever they are in their relationship with substances. And with respect to the social determinants of health, our government needs to focus on housing first, as everyone deserves a safe home, including supportive housing for people with a spectrum of needs. For example, people with brain injury related to non-fatal drug poisonings. When we send someone off to treatment, especially involuntary treatment, and we send them back to the street, they are 100% going to relapse into their use of substances. So if we don't create that bubble of support around them, including safe and supportive housing, then we're going to just be continuing along this crisis. Finally, we need harm reduction services and supports to meet people where they're at, to reduce communicable disease transmission, including HIV and hepatitis C, to connect to services and community, and to keep people alive long enough to make decisions about their substance use and recovery for themselves. So before I close, I kind of blew through that, so I apologize for talking fast. But I just want to introduce a new organization here on campus, the VIU Harm Reduction Alliance. We are very grateful for the renewed funding from VUFA Activism Grant for a second year. We are a group of students, faculty, and staff many of whom are here today, who are working to bring harm reduction to VIU campus. We have been involved with a number of community-based actions, including supporting the Doctors for Safer Drug Policy overdose prevention site at NRGH this past month. And in the spring, we'll be offering trauma-informed overdose response and naloxone training, as well as other educational opportunities like this one. If you're interested in joining us, follow us along on Facebook and Instagram, and reach out to get notified about monthly meetings. So thank you very much for being here today. I appreciate everyone who made the trip and came out today. I just want to remind everyone here, please never use alone and test your drugs where you can. Up here, I've got naloxone kits for you and fentanyl testing strips with instructions if you want to take some home for the holidays. And if there's any questions or comments or discussion, I'm happy to chat about that. Thank you.